You are live.
Hi, good morning, everyone. Welcome to session 4. My name's Andrea Sarsek. I'll be one of the moderators of the session this morning, and we're going to talk about how to provide timely, effective, quality of life, fertility preserving treatment. Hi, good morning, everyone. Welcome to session 4. My name's Andrea Sarsek. I'll be one of the moderators of the session this morning, and we're going to talk about how to provide timely, effective, quality of life, fertility preserving treatment. Hi, good morning, everyone. Welcome to session 4.
Abby, mute.
My name's Andrea Sarsek. I'll be one of the moderators of the session this morning, and we're going to talk about how to provide timely, effective, quality of life, fertility preserving treatment. Good morning, everyone. Welcome to session 4.
Abby, can everyone mute, please? I am muted.
It's on, somehow it's on repeat. Okay. Abby, Karen, are we live? Are we in the room? It's on, somehow it's on repeat. Okay. Abby, Karen, are we live? Are we in the room? It's on, somehow it's on repeat. Okay.
Is somebody watching this on the main stage as well? Because if you are, you need to exit out of the main stage and press on the backstage, please.
Andrea, I think you can get started.
Okay, good morning, everybody. My name's Andrea Sarsek. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center, and I'm one of the moderators this morning of session 4, where we'll discuss a case and review how to provide timely, effective, quality of life, and fertility-preserving treatment with our young patients with colorectal cancer. And I think if I'd like everyone, we have a large, wonderful panel of experts, really a well-rounded panel, and I would love to go around the room and ask everyone to introduce themselves. Dr. Stadler, maybe we can start with you.
Thanks so much, Dr. Sarsek. So I'm Sophia Stadler. I'm the clinical director of the Clinical Genetics Service at Sloan Kettering, and my focus is GI genetics, and I'm also a medical oncologist, and I treat patients usually with early onset colorectal cancer or colon cancer in the setting of a cancer predisposition syndrome. And I'm really here to talk about the germline aspects of early onset colon cancer.
Dr. Mullen?
Hi, Harvey Mammon. I'm a radiation oncologist at Brigham and Women's Hospital and the Dana-Farber Cancer Institute, specializing in treating GI cancers.
Dr. Woodward?
Hi, my name is Terry Woodard. I'm an associate professor at MD Anderson Cancer Center and Texas Children's Hospital, Baylor College of Medicine. I'm a reproductive endocrinologist who runs the oncofertility program at MD Anderson Cancer
Center. Dr. Ng?
Kathy Ng at Vanderbilt Ingram Cancer Center. I'm a medical oncologist that specializes in rectal cancer.
Dr. Abram?
Hi, I'm Dr. Janet Abram. I'm a former hematologist oncologist. I'm now working at Dana-Farber Cancer Institute and Brigham and Women's Hospital and specialize in palliative care. I'm a professor at Harvard Medical School.
Hey, Hayes, can you hear me?
My name's Amy Hayes, and I'm an oncology nurse. I work as a nurse navigator at the Vanderbilt Ingram Cancer Center.
Dr. Roth?
Hi, I'm Mike Roth. I'm a pediatric oncologist at MD Anderson Cancer Center, where I lead our AYA program. I also chair the AYA committee within the Children's Oncology Group.
And Manju George?
Hi, I'm Manju George. I'm a stage 3B rectal cancer survivor. I'm also the scientific director at PalTown, the nonprofit that supports Golden Town, a patient and caregiver support and education community. Happy to be here.
Krista Nelson?
Good morning, everyone. My name is Krista. I'm an oncology social worker. I've worked in Providence Cancer Institute in Portland, Oregon for about 24 years, and I'm also the president of the Association of Community Cancer Centers. Thank you.
Hadley Maya?
Hi, good morning. I'm Hadley Maya. I'm also an oncology social worker at Memorial Sloan Kettering, and I provide support to our patients receiving care through our Center for Young Onset Colorectal and GI Cancer. Happy to be here.
Thank you. And Dr. Mathis?
Morning, it's Kelly Mathis. I'm a colon and rectal surgeon at Mayo Clinic in Rochester, Minnesota.
Welcome, everybody, and thanks for being here on a Sunday morning. I think we should have a very nice discussion. For the audience, please feel free to text questions as we go along, anything that may come up. We will have a lot of time at the end of the session, and we'll address all of your questions, but don't hesitate to write them down as you think of them. I think we should probably get started. Abby, if you could please share the screen. Thank you. To the right is the presentation full screen mode. To the right of where your arrow is, that might be.
It's showing, let me try resharing. I apologize. It's showing up for me that it's full screen. So give me one moment, please. There you go. That's full screen, correct?
Yeah, that looks great. Thank you. Go ahead to the next, just to the, I think, 2 more slides, please.
Sorry, what do you want me to do? You want me to move the slide?
No, this is perfect. So this is the panel. We just introduced ourselves. Next slide, please. We'll get started with the case. One more slide. Okay, so the patient, this is a 28-year-old female, and she presented with a several-year history of chronic constipation for which she took laxatives. And then 6 months prior to coming to see the oncologist, she had a change in symptoms, tenesmus, so pain in the rectum, bowel urgency with intermittent rectal pressure, like really deep pressure down in the pelvis, which was worse with standing for a long time. So ultimately, she presented actually not to the oncologist yet, but to the emergency room after dealing with these intense new symptoms for 6 months. And in the emergency room, she had a CT abdomen and pelvis, which showed a moderate amount of stool in the ascending colon, so on the right side of the colon, thick-walled appearance of the rectum, about 6 centimeters from the anal verge, so just about halfway in the rectum, down to the anal rectal junction. This prompted a colonoscopy. This looked abnormal and prompted a colonoscopy that showed a non-circumferential mass in the distal rectum all the way to the anal verge. And a biopsy returned as invasive, moderately differentiated adenocarcinoma. Next slide. In terms of medical history, so she's a 28-year-old attorney. She had no other medical history, was not taking any medications. A father had a history of having 2 to 3 polyps removed a few years ago, but he was of the age of screening. She lives alone in the city, about 5 hours away from her parents. BMI was 22, so healthy, not overweight. Exam was otherwise normal. So maybe we can stop right here before we talk about the rest of her workup. So maybe Manju, for you, just in terms of the fact that she had these symptoms for years, and ultimately it took her really 6 months of really severe pain and something really very abnormal to finally present to the emergency room. This is something that you typically hear from patients, especially as a patient advocate in our young patient population.
Yes, unfortunately, that is the case. So it seems that there was a study earlier, and they said that they found that it takes about 270 days from the onset of symptoms to diagnosis for young patients, because most of the time their symptoms are dismissed as something benign, like a GI upset is something that everyone has, and usually they are not given the medical attention they deserve. That has been our experience in our groups.
Yeah, absolutely. And we've seen that. We've seen those data published, and I think we see that as oncologists routinely in these young patients. Or on the other side, I think, is also the fact that they're so young that they themselves dismiss their symptoms, or they're busy and just don't address these symptoms, or perhaps in denial a bit as well in terms of what this could be. Dr. Eng, do you see this a lot in your clinic as well with the young patients?
Definitely. This is a common discussion point where they've had symptoms in retrospect, and you ask them how long it's going on. It's been several months, sometimes even up to a year, and they just didn't recognize it, or they had reported it to their primary care physician, but it failed to be recognized or was attributed to hemorrhoids.
Right. So I think one of the important messages for us as well is just to get this message out about the rise in early onset cancer, so that people pay attention to their symptoms and seek medical attention when needed. In terms of other risk factors, Dr. Sadler, could you speak a little bit about her family history? Is this something that we're typically used to seeing with our young patients, or is this kind of unusual in that she really doesn't have a significant family history?
Yeah, no, that's a great question. So interestingly enough, about 70 to 80% of our patients with early onset colon or rectal cancer do not have a family history of the disease. So you often see this where maybe someone in the family had a few polyps on colonoscopy. I always think it's important to get the pathology of the polyp in the family members, and also to make sure that in fact the parents have had their colonoscopies. And I also like to always ask about siblings, how many siblings they have, because it will help in terms of who needs a colonoscopy at a young age potentially. So I'd like to usually take the first and second degree family history pretty broadly, even if they don't tell me that they have a strong family history of colon or endometrial cancer. Great,
thank you. Okay, so moving on with this patient. So young woman, newly diagnosed rectal cancer, and the pelvic MRI confirms this, showing a tumor that arises from the right lateral wall at the level of the levator. Distal edge of the tumor is about 2 centimeters from the anal verge, and the tumor abuts the internal sphincter. So it's by MR staging, which is our typical clinical staging now for rectal cancer, T3N1B, so a clinical stage 3. So Dr. Mammon, if someone like this is going to be referred to medical oncology and radiation, can you talk a little bit about the treatment here, and if, from your perspective, radiation is definitely a part of the treatment plan and sort of the paradigm of total neoadjuvant therapy and therapy in general for rectal cancer?
Sure. So, yeah, I mean, these are this is, I mean, it's a great case because it's so illustrative of so many issues.
Congratulations.
But it's also a terrible case, because when you see cases like this on your schedule, you know the discussions are going to be very difficult, and there's no perfect solution, and compromises are going to need to be made. So, if this were the exact same story in a 65-year-old woman, I mean, nothing's straightforward in rectal cancer anymore because there are so many choices on how to treat rectal cancer, but it would be a lot more straightforward. A distal tumor like this, sphincter preservation is somewhere between impossible and unlikely. You also know local recurrences are higher for distal tumors than proximal tumors. And so, to the extent that there is a standard treatment these days, it probably would be some type of total neoadjuvant therapy approach. This patient started with chemotherapy, which is, in terms of survival, is equivalent. She was probably treated before the OPRA results came out that suggested, with the goal of avoiding a TME, the preferable sequence is to start with chemoradiation, the chemotherapy. But either way, this is a patient that, under ideal circumstances, if the treatment would be all three modalities. She would want chemotherapy because she's clearly at risk of distant spread with T3N1 cancer. She would want radiation for local control, given, again, that stage and the distal location. And the standard treatment, although I'm sure that we're about to start talking about non-operative management soon, would include an APR most likely as well, if we wanted to maximize disease control. Now, I'm sure what we're going to get into is, the number one priority is curing the cancer, but there are other quality of life priorities that also need to be considered, including fertility and potentially avoiding a permanent colostomy. And that's where we start to make compromises among whether all three treatments are needed for every patient.
Right, exactly. Thank you. Yeah, so I think this, you just brought up a very good point, right? This is exactly the issue that we face with our very young patients, is that it is obviously most importantly about cure and cancer outcomes, but there is so much that comes along with not only treating the cancer, but treating the patient and addressing all of the critical issues, which of course are important even in a 65-year-old. Bowel function, sexual health, physical appearance are critical, but especially in our very young patients, and especially in patients as young as this one, where we have to think about not only the psychosocial needs, but also the actual nitty-gritty of fertility preservation, of the wishes of the patient. So Dr. Woodward, just a question for you. Meeting someone like this, how early should we send them to you? What are some of the things that we can offer her before we get into it, how she was treated? But we really feel in medical oncology this needs to happen early, of course, before any treatment. Could you speak to that a little bit in terms of timing and what we can do for her now?
Absolutely. So we do encourage that these patients be referred to us as soon as they have a cancer diagnosis. And as many of you are aware, ASCO has a set of guidelines that were developed many years ago and have been updated recently. And it admittedly says that when patients are referred early, it leaves their options broadly available. So when they have more time to pursue things like egg or embryo freezing, they can accomplish that without significantly delaying the onset of their cancer treatment. So we do want to see these patients as soon as possible, not only because it gives them more options and more time for options, but also gives them more time to think about things. Because when we talk to patients about fertility preservation, we encourage them to take kind of a bird's eye view instead of just simply, okay, do I want to freeze my eggs or sperm or not? Because they also have to answer questions about, well, if I get radiation and I can't carry a pregnancy, do I still want to do this? Or if I have a genetic mutation, do I want to do genetic testing? So it's a lot more complex than just, do I want to freeze my eggs or
Absolutely. So Dr. Sadler, to that point, would you suggest for someone this age, and maybe if you could speak to all the way up to 49, 50 as we define early onset cancer, to have genetic testing prior to thinking about egg harvesting or at some point in the treatment? How important is that?
Yeah. So the first and foremost thing that I think needs to be done is assessment for the mismatch repair proteins or microsatellite instability assessment on the tumor, because that may really dictate treatment to some extent. We know that mismatch repair deficient or MSI high tumors respond less well to FOLFOX treatment. So we would want to know that upfront. The great thing is that it's been demonstrated by multiple pathologists in multiple papers that using the colonoscopy biopsy specimen, you can definitely do immunohistochemical staining as well as MSI analysis with PCR methods. So I think that's kind of the first step. Now, presuming that it's a normal result, it's a mismatch repair proficient result, then I think especially in the age group of less than 35 at diagnosis, I think multi-gene panel genetic testing is a reasonable undertaking. And the reason that I sort of split up the very early onset, so under 35 versus the 35 to 50, which is still early onset, is that data has shown that it's really the under 35 cohort that has the highest germline risk. So if you look at Heather Hampel's data from JAMA Oncology, 450 early onset patients defined as less than age 50, the prevalence of mutations in that cohort was about 16%, again, under 50. In our data that Dr. Sursak and I are putting together, we found that the prevalence of mutations in the under 35 cohort was actually nearly 24%. So really, really high prevalence, as opposed to lower, about 14-15% prevalence in the 35 to 50 age group, and then even lower prevalence in the over 50 population. So I really think that this under 35, or what I refer to as very early onset colon cancer patients, are truly enriched in germline mutations. If you break down those numbers and you just take the really high risk genes, like that's your FAP, so APC mutations, your POL mutations, your mismatch repair deficient or Lynn syndrome associated mutations, they account for about 12% of the very early onset versus 6% only in the over 50 population. So I think utilizing a multi-gene panel is the right way to go in this setting, partially for the treatment, meaning the MMRD you need to know, but also obviously partially for future risk assessment and for PGD and all of those options.
Great, thank you. And just kind of covered the sort of the initial presentation and diagnosis. We've talked about that this tumor is very low. Dr. Mammon mentioned that very likely radiation, even if we start with chemotherapy, radiation will have to play a role. Ideally, we don't have to do surgery, but the correct plan is to include surgery. And so this patient will very likely end up with a colostomy. And treating young patients in particular, we do see the effects of this psychologically. It's not easy to deal with. Hadley or Krista, or both, could you address a little bit if you feel that if early intervention, early perhaps therapy or psychosocial support perhaps would help patients manage the long-term effects of treatment a bit better? Do we have any data for that, or is that kind of what we feel will be really optimal for our patients?
Well, absolutely, and thanks for bringing that up. What I've heard everyone say is early referral is important, and I think that is also true with the psychosocial assessment. So as clinical social workers, oncology social workers, our number one goal is making sure we meet that patient where they're at and get a sense of who they are, who their support is, if they have any barriers to care, their socioeconomic status, workplace issues. You know, we talk about all of these different appointments they need to get to. And quite often when we work with young people, it's the recognizing that their work is important, their families are important, and these are all really large decisions. So having an opportunity to take a pause and really think about, like we mentioned earlier, fertility, or thinking about these surgical changes, really getting a sense from them if their number one priority what they're willing to balance. So we do know psychosocial screening. So right away when patients are diagnosed, you asked about evidence, and there is a lot of evidence saying that screening, just the act of asking people about their psychosocial distress, does reduce their stress. Of course, looking to treat if there's a trauma history, that would be very important with this diagnosis. Also, anxiety and depression. But I want to turn it over to Hadley, and then I know our nurse navigator colleague as well might have some things to say.
Thanks, Krista. You covered most of it. I would just add on specific to the colostomy and surgery. In my experience working with these younger patients, it is such an enormous adjustment and really impacts quality of life and body image and conversations with family and friends and dating and all of the different layers. So being able to start to have these conversations earlier, as Krista mentioned, aside from the assessment, but just providing support and psychotherapy around anticipating the adjustment and then making the adjustment to life with a colostomy, I would say is hugely important.
Great, thank you. And Amy, in terms of nursing and support, could you comment on that a little bit? I find that really key in our treatment, throughout, and also so into follow-up, a good relationship with the nurse goes a long way.
Absolutely. So, as a navigator, you're meeting that patient at that initial, almost actually before they come in the door, right? Their initial findings, now they're coming to this new place, a cancer center that they've maybe never, been into before. And so as the navigator, you are right there meeting them and figuring out who they are, how they're handling this. And with all these specialists that they need to see, you're kind of there guiding them to each visit, helping identify, hey, you've got to see our social worker or our financial counselor. We got to line you up with all these other specialists. They're going to be valuable members of your care team, and always there, answering questions and reinforcing information along the way as their navigator. It's an important piece for their care team.
And then Dr. Abram, in terms of when we hear palliative care or supportive care, some patients are often a bit taken aback because of the word palliative, but really we think of it as a broader term in terms of supporting through care and managing potential toxicities from treatment. Could you comment on that a bit?
Andrea, I'm happy to hear you say that, because I think it's so important that the oncology team include palliative care if that's available. Not only can we help your patient suggest some issues around her current pain, like a B&O suppository, if she could tolerate it, might help that tenesmus a lot. But Harvey talked a lot about the decision making this person's going to have to make. And so along with the nurse navigator and the social workers, palliative care can really help around identifying goals of care for these patients and their families, can help them be a neutral arbiter, if you will, and help them sort out and run through with them the different possible scenarios and help them articulate those within their families so that they can be clearer when radiation oncology surgery and chemo are all offered. So if we're part of that core team, we often have more time in a way, and we could unpack all the medical speak and really help patients and families in these hard decisions.
Great, thank you.
And to that note, I just wanted to jump in. I was recently working with a young person with this diagnosis, and I talked about palliative care, and she was, I think we worry people will think we're not hopeful for their future or something. And her message was, why have you been keeping this from me? There's all this extra support. So I think we have to also kind of be aware of our own bias when we're referring patients and recognize it is really this additional amazing support for them.
Absolutely, thank you. And Dr. Roth, I know we've covered a lot in terms of, but specifically in your experience with the AYA program, I know, and unfortunately for many of us, our patients are getting younger and younger and are out of the area even of young adults and in the teen range. I know for me personally, and so as this incidence is rising in our very young patients, is there anything additional that we haven't covered that we need to think about in our adolescence that perhaps may be different or that would be helpful to think about?
Yeah, it's a great question. We see patients 15 to 39 within our AYA program, and I think it's important to acknowledge that there are definitely disparities in the quality of care and access to care that our young patients receive depending on the treatment setting. So as patients get older through adolescence into their early 20s, they're less likely to be seen at a pediatric site, more likely to be seen at a medical oncology site, and more likely to be seen in the community. And despite the fact that we have all of these world experts on the panel here, a lot of these resources aren't available in the community setting, or the providers and the patients don't have access to many of them, which really suggests the importance of having centralized resources for all of these patients. So I would strongly advocate for everyone in the community setting to refer patients to some of the great young adult resources that are available, the young colorectal cancer patients as well as other AYAs. It's incredibly important that all young patients with CRC and other cancers have access to fertility preservation, psychosocial support, and other key features that really impact their health, their survival, and their quality of life.
Thank you so much. I think we can jump back into the case. Abby, if you don't mind sharing your slides, and Dr. Yu has joined us. Hi, Nancy. So I think we've covered the slide.
Sure, I can pick this up. So as Dr. Stadler had mentioned before, testing the tumor for microsatellite instability is one of the key next steps. And this was done in our young patient. And as we know, the majority of the young patients actually do have microsatellite stable tumors. Lynch syndrome and Lynch-related tumors only account for a relatively small proportion of them. So this patient was not surprisingly had a MSS tumor. And we also did a few more somatic tumor testing on her. Next slide, please. Oh, sorry. So before we go to the additional somatic testing, at our institution, we did start a universal germline testing program for patients under 50. In our data, and just to echo what Dr. Stadler had already talked about, the proportion of patients with a germline mutation that's actionable is definitely very high when we look at the 18 to 35 age group. I think in our series, it was as high as 33%. The proportion drops a little bit when you include 18 to 50, but that's still about 17 to 18%. So almost 1 in 5. And so, probably for the last year and a half, we've been offering germline testing for everyone. And so this patient did undergo germline testing on a multiplex panel of 47 common hereditary cancer genes. And again, probably not surprising because it fell outside of the 18%. She didn't have any actionable pathogenic germline mutations, but she was found to have a couple variants of uncertain significance on her germline. Dr. Stadler, do you want to comment on kind of use of multiplex panels and finding VUS and explaining that to the patients? It's one of these.
Absolutely. It's sort of what the core of what we do in genetics, but basically genetic alterations come in different shapes and forms. And so you can have genetic variants that are truly, or what we call pathogenic. They're classified as being pathogenic or likely pathogenic, and those are given evidence levels of 4 or 5. And those are really, those are the mutations where we think that they alter the function of the gene. Or you can have a level 3 evidence, which is what a variant of uncertain significance is, where we are not sure. There is a genetic alteration there, but we are not sure whether that genetic alteration actually causes a defect to the function of the protein. And generally, in the majority of these VUSs that the patient had, end up being downgraded in time. The more genes you test, so you had a panel of 47 genes, for example, and the more genes you test, the higher the rate of variance that you're going to find. Also, in non-whites, there are higher rates of variance, only because more whites have been genetically tested, so we have a better understanding of the genetic alterations in whites versus non-whites. And I think this is one of those issues when we look at diversity in medicine, we also need to increase the genetic testing diversity to ensure that everyone is getting access to genetic testing, and not just access, but also good interpretation of their genetic test results. So I think these three genetic variants, we didn't talk about the patient's ancestry, but these three genetic variants are probably just what they are. They're variants of uncertain significance. We usually tell patients to follow up with us in a year or two in genetics to see if those variants have been reclassified. Many commercial laboratories and our internal laboratory at Sloan Kettering, we actually reclassify variants every 2 to 3 years, and then we send out updated letters to patients if their variants have been reclassified.
Yeah, thanks so much. She's actually South Asian, so I totally agree. Much higher prevalence of US in the non-white population.
Andrea and Nancy, can I just, I just think it's important to clarify. You know, for diagnostic purposes of the workup, I presume that a CT scan of the chest was completed, because you only mentioned MRI of the pelvis.
We're gonna get to that right now. I think we have it, but absolutely.
Okay, and then I also think it's really important for patients, you guys mentioned exactly where the tumor location is. I think that's, you know, I think all patients should really try best to get that information. Sometimes they don't have that information when they're just, you know, when they're diagnosed, they basically only know they have rectal cancer.
Yeah.
I completely agree. Particularly, you know, I think many of the young patients end up, you know, having their colonoscopy at one place and then going to a different location for treatment. And that's really critical information for the treatment team. Could we maybe advance to the next slide? I think we talked about this already. Many of these issues were already discussed. Let's advance that. Yeah, I think maybe any other comments regarding
we went through most of this. I think we can touch on COVID. I think it's thankfully a bit less of an issue now as people are getting vaccinated. Certainly the hospital setting feels much safer, but initially during COVID, this was a major issue for us, not only with chemotherapy, but also with radiation, particularly for rectal cancer. At Memorial, we did long course radiation, so that's about 5.5 weeks daily, except for weekends. And so the patient had this repeat exposure, so we implemented short course radiation, which we don't need to get into now, but there is the option in the curative setting of short course without chemotherapy for 5 days versus the long course for 5.5 weeks. We have since changed back to long course for many of the patients as the rates of COVID are at least a bit better controlled, and we feel safer for the patients and for staff. So that's just something to touch on. I'm not sure if other centers still have COVID protocols in place.
Our only limitation is we only allow one visitor with the patient, but otherwise we've been doing everything fairly standard.
Okay.
Yeah, I mean, the only thing I was going to add to that is, you know, even in COVID when the numbers were high and wanting to universally go to the short course for radiation, when the goal is non-operative management, there is no data for short course and non-operative management. So that was, you know, if that was on the table as a consideration, then you have a, you know, you might have to not follow those COVID guidelines if that was what the treatment intent was.
Any comments about treatment, Dr. Mathis?
No, I agree with what's been said. If I was seeing her for the first time in the clinic, I would do another exam. I would do another Plex6 so I can see the tumor myself, and then I'd start that conversation. She obviously needs neoadjuvant therapy regardless of how we choose to give it. So surgery is not going to be an upfront consideration, but I would still spend time with her going through the various scenarios and let her know that, should she require surgery, there is a very high rate of colostomy with these very low tumors, as has already kind of been discussed. And I would involve our intrastomal therapist right away. I think the more information for patients, the better. So having that education and opportunity to learn from people, who do this every day, what it means to have a stoma and how they manage that. I think that's critical in the early stages of treatment.
Do the different institutions have any sort of kind of pre-set up patient network for patients, younger patients, who are facing decisions regarding an ostomy at all? That's like formally said. I mean, I often have young patients ask me, and then I have some patients who's expressed, if anyone wants to call me, happy to talk to them. So I have this informal thing that I do, but do any of the institutions have something more formal at all?
As part of our Center for Young Onset Colorectal Cancer, we do have, it's a formal sort of setup, it's virtual, but we put the patients in touch early on with support groups and with social work. Everyone sees Hadley. All of our visits are seen by Hadley initially, and then she kind of, they're informed of all the support services that we have available, including patient support, and then Hadley feels the patients out for more specific needs. Hadley, maybe you want to address a little bit how much the colostomy, comes up specifically for rectal cancer patients, or how you kind of manage what their needs are based on your initial conversation with the patient.
Sure. Yeah, I mean, I think that the ostomy specific support, I find that most of the patients who are preparing for surgery are interested in, the younger patients are interested in talking to somebody else who's been through it. So we have a patient-to-patient program. It's a peer support program where we can set, formally match a former patient with a current patient, that they can provide support to each other. And we also have an ostomy support group that's run by one of our ostomy nurses and social workers. So the patients typically attend once they've already had the surgery, but they can attend in advance as well to get some sense of what to expect. And then there are a variety of other resources, both at MSK and in the community, that I often will connect patients just for information gathering and more peer support, but in an informal way.
If I may say something, we have in Colintown, we have Youngstown, which is a neighborhood for patients diagnosed less than 40 years of age. We have about 250 patients in there. And we have a Rectalburg neighborhood, which is really focused on rectal cancer. There is a lot of discussion there about, watch and wait, about location, radiation and side effects, and about ostomy. Discussions from people who had a good life with an ostomy, travel the world, do skydiving, those kind of things, and about patients who have had a terrible time with the ostomy. And we have patients who have undergone surgery and who have an excellent life, and also patients who don't have, who have lots of trouble and LARS and all of that. These groups, then the patients, the newly diagnosed patients, get to see the range of experiences and kind of get to know what are all the different things they have to talk to their care team. That's something that we provide in Colintown.
That's great. Thank you for that information.
I was just going to chime in. I'm the director of our Young Adults with Cancer program, and it's not just colorectal cancer; it's all cancers for patients between the ages of 20 and 45. But we also have, and Amy's well aware of this, significant resources available for patients specifically to help address these concerns. And we do try to arrange kind of a buddy system if the patient is agreeable, because obviously it's a very personable experience of what they're obviously thinking about, and quality of life and perception of others, as well as sexual function as well. So we do have that available as well. And we also utilize other groups such as Gilda's Club. They also have a young adults program, which I think is fantastic.
Yeah, so at the Dana-Farber, many of you know my colleague, Dr. Kimmy Ng, who's very involved with this organization. And the program is similar to what others have described. I just wanted to really thank Manju for that set of comments she just made, because I spend a lot of time talking to these patients, and everybody wants to know what's going to happen, what's the outcome going to be, what if I do this, what if I do that. And I think the point that Manju just made about the variability of outcomes is so important. And on one hand, sometimes I feel like I'm not helping patients because I'm telling them so many different things could happen with the same treatment. On the other hand, I think we have to have the humility and the honesty to say we don't know, and we've seen this wide range of outcomes, and that I think that added uncertainty to what's already a very hard decision makes this a very stressful thing for the patients to be going through. But I think taking that on directly, as Manju just described, is really important.
Absolutely, I agree. Maybe we can continue with the slides, Abby.
Yeah, so I think this is some of the in-house panel of 400 genes with hotspot mutations. And her panel came back with lots of mutations on her tumor. So maybe I can ask Dr. Ain and Dr. Sursik and Dr. Stadler to comment.
I guess, Nancy, the one question is, because this is an early stage patient, was this sent off as part of a protocol, or is that this normally wouldn't be sent off on an early stage patient?
Totally agree. Unsure, but it was done.
And the reason I bring this up, and Andrea can comment as well, is just because the reason that we order sequencing for most patients is because we're thinking about subsequent lines of therapy and more targeted therapy, whereas in the setting of a stage 3 rectal cancer patient, we're more thinking about sequence of therapy and how best to utilize the radiation therapy and the surgical approach, etc. It's not necessarily specific to any specific targeted therapy, which has not been beneficial thus far in the setting of rectal carcinoma. Andrea, do you want to comment?
Great comment. I appreciate that comment, because I think many of the younger patients and even their referring providers may be under a lot of pressure to actually order these things.
Yeah, that's a great point. I think absolutely. I think people are asking for them more and more. But to Kathy's point exactly, I think it doesn't affect our treatment, even the sequencing, or if we choose radiation before chemotherapy. Nor can we say, okay, there's potentially this bad mutation with a bad prognostic indication, therefore we have to do surgery. It does not alter treatment of locally advanced rectal cancer at the moment at all, except if the tumor is mismatch repair deficient or MSI high. That's really the only, we do have clinical trials addressing MSI high tumors that differ from the standard approach. But to your point, it's research at this point, but then patients do come to us with these mutations, and we need to discuss them, and sometimes it adds anxiety, sometimes it's helpful. I just always say this is informative. Hopefully we don't need it. You'll get through your treatment, you'll be fine. But we know the tumor genomics. I think this patient in particular is pretty interesting, though. It looks like a poly tumor, which would explain the many mutations. But again, no effects on treatment, no difference in treatment planning at the moment, although we are learning more about poly tumors and sensitivity potentially to immunotherapy, or not potentially, but sensitivity to immunotherapy.
Yeah, the only thing number one, the one thing that you brought up is that normally this would have been completed after the surgical resection, right? If you're going to do it, because that's the best amount of tissue that you will have to utilize this approach if you really want to do an NGS panel. Number two, it did have a POL mutation, if I'm correct, on there. Nancy, is that correct? It's really small. I couldn't really see it very well.
Sure that's good. Yeah, good.
But then again, the impact of a POL mutation, where we're thinking about potentially the role of immunotherapy, that would not be recommended, I think, this setting, because this patient was not MSI stable. I mean, not MSI high. The role of POL and immunotherapy in this young patient without a lot of data to support it in this setting, I think some of us would be a bit cautious.
Oh, I think all of us would be cautious. I don't know if that's exactly what I meant. I think it's interesting from a research question, but absolutely, this patient should be treated with curative intent, and we have a good standard of care protocol that we would employ for sure, regardless of age at this point in time. But it is interesting, and it is hypermutated, but that's for perhaps discussions in the future. Which is what happens when we send these panels. Lesson learned. So there you go. Abby, we can go to the next slide.
Yeah, so I think we've talked about this. In order to maximize the chance of organ preservation, we offer her pretty much a TNT regimen, which started with about 4 months of FOLFOX and then followed by long course chemoradiation. And she experienced some of the predictable potential complications. So maybe I'll see if the panel have any comments about these kind of expected complications, how to prevent them, how to treat them, how to support patients through them. And then maybe Dr. Mannon wants to talk about a little bit IMRT versus conventional.
Andrea, do you want to talk about sequencing and the role of a multidisciplinary tumor board?
Sure.
Sure, in terms of chemo versus chemo-RT. So sure. So I think, as Dr. Mathis pointed out earlier, I think it's critical for the patient to meet medical oncology, radiation oncology, and surgery early on, to have sort of a very informed discussion of the treatment sequencing, the side effects, what they're kind of up against, and that because it really is a multidisciplinary approach when we treat rectal cancer. Even if we get lucky and we can omit one of the modalities, we can omit surgery down the line, all of our patients are intimately involved with the surgeon, with exams, flexible sigmoidoscopies along the way, which are critical to assess tumor response. So I think that's very, very important, and I can't highlight that enough. So in terms of sequencing, so we've moved both chemotherapy and chemoradiation into the neoadjuvant or preoperative setting with the idea that we are treating the tumor as much as possible, as early as possible, and with chemotherapy early, we're also treating potentially micrometastatic disease, but not only that, we're also improving the response of the tumor, and with the hope that we get as maximal response and potentially non-operative management, which again is not part of the standard of care, in quotations, but is always kind of the hope, with very close follow-up and a very skilled team, I think, including a surgical team and radiology team with them. So that's the hope. That is always the hope in a patient as young as this with a low tumor where, as Dr. Mathis mentioned, this patient will, if the tumor does not go away, is going to need a permanent colostomy. And so what we've learned is that when we give the total neoadjuvant therapy up front, our pathologic complete response rates are significantly higher. People tolerate chemotherapy much better if we give it early as opposed to giving it after chemoradiation and surgery. where most of the patients have, not all of the patients have a permanent ileostomy or colostomy and have trouble managing the bowels. Some patients are just exhausted and don't want chemotherapy. So that's the idea, and we've seen that now in several retrospective as well as prospective trials, that really chemo delivery is optimized when we give it early on. So I think the debate still stands, though, within TNT, which sequencing is better. Do we do chemoradiation up front and then chemotherapy, or do we do chemotherapy up front and then chemoradiation? So there have been a few trials that address this question of giving chemoradiation up front, where we really saw very nice increased responses with chemoradiation and then subsequent chemotherapy in terms of increasing the pathologic complete response rate. But the question is it just simply a measure of time? In other words, are we just giving the cells more time to die, and when we do surgery later on, if we start with chemoradiation and then chemotherapy for 4 months, we're letting that process take place for a long time, and then the patients get to surgery and have a higher pathologic response rate? Or is there something to the biology of perhaps causing cellular injury with radiation and then adding good, strong cytotoxic chemotherapy like FOLFOX or CAPOX that then augments this response and leads to better pathologic responses? I think the way I think about it, and Dr. Mammon can comment on this as well, but in patients where we are trying to optimize total neoadjuvant therapy and where the tumor is very low or very big, very advanced, where radiation seems inevitable, I think it is acceptable to do chemoradiation up front followed by chemotherapy. I am forever an optimist, and I always think in patients where potentially we could omit radiation, maybe the better treatment option would be chemotherapy up front. Or if a tumor is much higher up, still in the rectum, but in the high rectum, we have data to say that radiation doesn't really add that much, that those patients would do well with just chemotherapy up front and then surgery. There's a large study called the Prospect study, which has finished accruing patients, and we're waiting for the data to mature. But that study asked the question of, okay, if we do chemotherapy up front, can we skip radiation and do surgery? And in some patients, that's a more attractive option. Perhaps in this young woman, if the tumor were not so low, she would opt to not do radiation, because we know that radiation would render her ovarian function, non-functional unless she had a transposition, as Dr. Woodward, as we discussed, or the uterus can't carry a child if it's radiated. And so all of these things are important. So all of these modalities, we talk about doing all of them. We want to cure the patient. That's the most important. But this is where really we have the opportunity to potentially, or at least try to, personalize care for each individual rectal cancer patient, not relying on genomics, but just on their tumor, and then most importantly on their response to therapy, looking at where the tumor location is, again, as both Dr. Mammon and Dr. Mathis highlighted, and Dr. Eng as well, where the tumor is really matters. Even just saying within the rectum is not, it's important, but we need to know exactly where. Is it sitting on the sphincter, or is it higher up, when we make these decisions in terms of which modality to start with first.
And I think it's important, as Dr. Mammon mentioned it earlier regarding the OPER trial, and just for people that may not be familiar, it's a randomized phase 2 study looking at either induction chemotherapy followed by chemoradiation versus chemoradiation therapy up front followed by chemotherapy, so people understand what that trial was. And it was a randomized phase 2 compared to historical controls. And the reason that I think Andrea and Dr. Mammon mentioned this trial is because that trial is specifically in the distal rectal carcinoma patient population. So T3, a node positive patient population distal. So it demonstrated that if you receive chemoradiation therapy up front, there appeared to be a greater chance of non-operative management. So I think that's really important to mention specifically that trial, and also at this year's ASCO National, our annual meeting, we're probably going to get some additional updates.
Yeah, so there are a lot of important issues here. I mean, ultimately, all of these variations seem to result in pretty much the same outcome. So I think it becomes a matter of which is the highest priority and what to emphasize for a given patient. just quickly on the prospect trial, this patient actually wouldn't be eligible for that trial. So it's not going to help in a patient like this because it excludes patients with distal tumors who have a higher local recurrence rate. So it wasn't felt appropriate for that trial. So even if the prospect trial shows that chemotherapy without radiation is adequate treatment for mid and upper rectal tumors, we still won't know what to do with a patient like this. I would also say about TNT, it's definitely the trend and the way things are going. It has some clear advantages logistically and in terms of tolerability. I think it is worth keeping in mind, though, that the main conceptual advantage of starting with chemotherapy is early treatment of micrometastatic disease. And the data haven't borne that out, at least not yet. It seems the survival rates, disease-free survival, distant metastases are the same regardless of sequencing. Maybe that will change when more data comes out. And then I would agree with Kathy. Our main, there are other, non-operative management started in Brazil. There's a lot of European data, but in this country, OPRAs are kind of our lodestone for non-operative management, and it's exactly as Kathy said. It was a randomized trial, randomized phase 2, but still randomized, and with the goal of avoiding a TME, the sequencing was better by starting with radiation, and it didn't seem to affect sort of other endpoints one way or the other. They were very, very similar with either sequencing. So I think from a survival point of view, they're equally acceptable sequences. But if the goal, as at least in that trial, was non-operative management, then starting with radiation probably makes more sense. That may be less of an issue for a proximal tumor where sphincter preservation isn't an issue. And again, in this patient, the priority was avoiding the ostomy. If the priority were maintaining fertility, you would take a very different approach and definitely start with chemotherapy. So it really does require, what Dr. Abram described and what other people described is, all of this has to be discussed very clearly with the patient before any treatment is started to understand what the patient wants, what the patient's priorities are, and what the different directions of getting to the desired endpoint are.
Andrea, out of curiosity,
if I may say something, if I were a patient in this case, excuse me, the pole mutation, I would probably, if that can be acted upon with a high TMB, I could get immunotherapy, and that would really affect how my tumor behaves. Whether there's any chance that I might preserve the sphincter, I think that would be a discussion that if it were my case, that I would have with my team.
I think it's a good point. The issue is that it's not approved immunotherapy for in the neoadjuvant setting. So unfortunately, it wouldn't be an option outside of a clinical trial. Perhaps then you could find a trial that may offer immunotherapy. And there was one that recently, in addition to standard of care, there was one that recently closed to accrual that was just reported. So, I think it would be a good discussion if perhaps looking for a clinical trial, then I think that would be an option, but not as standard care. Kathy, you had a question?
Oh, I was just going to ask you what because it produced 23 with the FOLFOXIRI, granted this is a young woman that's 28, so I'm not sure if I would go that approach. But, that was for a run-of-the-mill stage 3 rectal cancer patient population, and the data was actually quite compelling. I've not utilized it myself, but the data is quite compelling. I was just going to see, has anybody started utilizing it at your institutions?
Yeah, so the PREDIGE study basically treated patients, as Kathy mentioned, with T3, sort of stage 2-3 disease with FOLFOXIRI or FOLFIRINOX. So what we typically give plus the addition of irinotecan, with the question of, do we optimize response? What is the pathologic complete response rate? And so we have done it in very select patients where we really needed to get an optimal response. For example, the T4B tumors invading into the bladder that would require quite morbid surgery if we did not optimize response. And in higher tumors, not in distal tumors where we would utilize radiation, but in higher tumors where we wanted to really maximize response, but very selectively, very few patients, at least me personally.
Yeah, so I'd add to that. Our approach at the Dana-Farber is exactly what Andrea described at Memorial and Sloan Kettering, but I know our colleagues across town at MGH are using it pretty routinely. So I think people are reacting to the data differently.
Yeah.
We don't know if this is going to happen yet, but many of you are on the recent rectal task force meeting where the Oprah successor is likely to be a randomization between induction with FOLFOXIRI versus FOLFOX. I hope that trial goes through. I think that's a very well-designed study, and I think it will really help answer exactly this question. Because the randomization in PRODIGE was it altered the chemotherapy and the sequencing, so it's hard to draw conclusions. But I think if this successor to Oprah, if the Janus trial goes through as proposed, and it still has to go through the steering committee, I think that would be a great study, and we'll know a lot more afterwards.
Abby, should we go back to the slides? I think we didn't touch upon so chemotherapy in terms of how we approach our patients. Next slide, please. So just before we get to this, maybe the medical oncologists, Kathy and Sophia, could comment on just in terms of how we prepare our patients for potential toxicity, what the discussions are, and whether you've seen more or less toxicity in our younger patients compared to some of our older rectal cancer patients with FOLFOX alone. Abby, can you go back one slide? Sorry. Maybe one more. Yeah. So just lists some of the potential toxicities, but please share your experiences.
I mean, the print's rather small, so I think it's FOLFOX times 4 months here. But in my experience, I would say the young patients tolerate their treatment extremely well, and I would also offer CAPOX as an option, as a potential option as well, if they were more interested in that approach. I think overall, most young patients obviously have less comorbidities, and so they're able to tolerate their treatment extremely well. But once again, it's all about communication and making sure they have all their supportive medications at home and making sure they're taking them correctly should they develop any nausea or vomiting or diarrhea, etc. And making sure they maintain their weight is extremely important, as you all know, especially in regards to surgical recovery, if they're going to go with that approach.
I could add that there's a couple of interesting caveats around vitamin D deficiency and chemo-induced peripheral neuropathy, since you have to use the oxaliplatin in this regimen. It's really important to replace vitamin D if anybody's vitamin D deficient. And at least in the breast cancer cases, exercise has been shown to diminish post-chemotherapy-induced peripheral neuropathy. You don't really have a lot of choice with patient selection here. We know that sedentary, obese, or diabetic patients have more incidence of it. So in the general choice, if you can use FOLFIRI or you can use FOLFOX in the sedentary, diabetic, or very overweight patient, you might decide to go with the FOLFIRI instead, but I understand that's not part of this regimen. And there's conflicting data about Effexor venlafaxine use in the oxaliplatin-induced peripheral neuropathy. The phase 2 studies, though, were really not encouraging, and the ASCO group did not pursue a phase 3 trial for the venlafaxine in that. The only one that's been shown to help at all, not by much, is duloxetine. So if you happen to have a patient who's somewhat depressed and also is going to be suffering from the chemo-induced peripheral neuropathy, it's useful to try duloxetine kind of as a twofer there. We don't know much about CBD cream for the fingers, but it would be really interesting to study that. And of course, you can't use the cold therapy that you can use for Taxol, which has been very effective for Taxol, but of course would be contraindicated here.
Well,
and I'm sure
actually, to that point, I'm glad you brought that up, Dr. Imers, because we've done it actually, and maybe Manju can speak about this in a bit more detail, but we have done it in a number of patients now and seen really great results, and they do tolerate the oxaliplatin infusion, but I know that Manju is working on this. I'm not sure if she's still on.
That would be great if you guys
Yeah, I'm here. Yeah, I'm here. So in Colin Town, we really recommend, I don't know why my camera is not showing.
Okay.
So in Colin Town, we actually recommend that people start icing, which is actually either exposing their hands and feet to cold packs or also to, have ice.
I mean, that was very good data in the Taxol group with people using their own one hand and foot as a control.
Everyone.
Very exquisitely tested.
Yeah, almost everyone.
I'm sorry, Manju, go ahead.
Almost 90% of the people seem to have no the acute cold side effects of oxaliplatin. They don't seem to have it at all with icing.
That's
really
greatly.
Yeah, that's been my experience anecdotally.
So it'd be great if
you trial. There's a prospective trial that's either ongoing or planning. I know we had discussed that.
Yes, I think there are Dr. Axel Grothy at West Cancer also trying it in his patients. And in Colin Town, we actually recommend that everyone who's trying K-Pox or Folfox or Folfirinox or whatever his oxaliplatin, try icing. And we know that there is some resistance nurses and some oncologists, but gradually, doctors are willing to have the patient tested. They're especially scared about the laryngospasm that some patients may get. We, because patients are now, the general attitude that it might be bad for them is going away. I just kind of wanted to bring that up, saying that it seems to be quite effective for the acute oxaliplatin side effects.
I do want to chime in against about what Dr. Abraham said. We actually looked at data when I was at MD Anderson regarding reducing neuropathy. Please keep in mind we are only providing a short duration of oxaliplatin-based therapy for rectal carcinoma. So obviously the cold-induced neuropathy is a different story than the concerning chronic neuropathy. But in regards to chronic neuropathy itself, our data at MD Anderson did not show benefit for utilizing vitamin D or vitamin B as well. We published a small study on that previously. So I just want to make sure to clarify that in the sense that we have looked at it before at Anderson.
Kathy, could you tell me, I'm not suggesting adding it. I'm wondering, were any patients vitamin D deficient that you then repleted it? That's the data that I had read. Not adding.
Yeah. Okay. Yes. If they are deficient, that's a different story, and either myself or the primary care physician will make sure that it is obviously repleted. Yes, that's a different story.
Yeah, we're on the same page. That's all I was recommending, and thank you for clarifying that.
And Harvey, could you comment on the side effects, short and long term, of radiation? And I think maybe it would be a good idea for this particular patient who's a woman, but also in a man, in a young man, what some of the things that we need to think about. And then Dr. Mathis as well, if you could talk about both for surgery.
Yeah, so that could go on for hours, unfortunately. I won't. For both men and women at this age, the number one issue by far is fertility, because it's virtually guaranteed that both men and women will be made infertile by pelvic radiation. And for men, sperm banking is a pretty easy solution, although even that runs into some complications. As Dr. Woodward started to talk about, it's more complicated in women. We do a lot of oophoropexy to maintain hormonal function, but that doesn't always work. And then of course, even with egg harvesting or embryos freezing, the radiated uterus is probably not going to support a pregnancy, so it's going to involve a surrogate. So these are all really, I think for a lot of my young women, like this patient who we're describing today, this is as upsetting as the cancer diagnosis. And so this is a huge issue that we spend a lot of time on, and in a way the other side effects are, to me, are all secondary to this one, and that's why it's such a difference between seeing a young patient versus an older patient who's postmenopausal or already has a family. It's really like two different diseases because of that. The other side effect are things people alluded to acutely. And again, as I mentioned earlier, that the variability is tremendous, and I'm sure all of you are very experienced clinicians, so you've all seen this too. There are patients who just sail through this treatment and it's like nothing ever happened, and there are patients who are hospitalized with severe enteritis, dehydration, sort of everything in between. Late effects, fortunately, outside of fertility, I would say most of the literature shows are fairly mild. We worry about bowel function, rectal urgency, rectal frequency, incontinence. These are all things that happen, but at relatively low numbers. There's certainly an increase in erectile dysfunction in men. Less so with young men, actually, but it's there. I'd say those are the common major side effects. I haven't seen literature on tolerability of radiation by age. My anecdotal experience is that it's still very variable. I have these frail 80-year-olds who have multiple comorbidities and just get through the treatment like nothing happened, and I have these really healthy 45-year-olds who have no comorbidities and look great and just have every side effect in the book. So in my own anecdotal experience, I wouldn't say that the ability to tolerate radiation corresponds with age, but I don't really know of good literature to back that up one way or the other.
I would say that that's the same for chemotherapy too, that there is immense variability in tolerating treatments in young adults. Some of them tolerate it great, while others really just suffer every side effect, I totally agree.
Terry, can I ask a question about, because I know I've referred patients to you before when I was at Anderson, and I was a bit frustrated at times just because when we're talking about fertility, there's always these issues with insurance coverage and how best to approach it.
That is correct. So, we were just talking about disparities in treatment. And like, for instance, for men, for sperm banking, it's a lot cheaper, it's a lot quicker, it's not invasive. At MD Anderson, we even, through the AYA program, have a program that pays for sperm banking. But when it comes to our women, we don't have that. What we do have are programs that will help subsidize the cost of egg freezing. So instead of maybe paying $10,000, the patient can pay maybe $6,000 plus the cost of medications. And a lot of times we can get the medications for free with a cancer diagnosis. So a lot of times these patients, this is what makes them decide not to do it, is because they can't afford it. There are some organizations out there such as Livestrong, which subsidize costs. There's also a newer organization outside of New York, but they also have grants that can be used in Texas called the Chick Mission, who will actually pay for the cost of egg freezing for women. And I think they give about 100 scholarships per year. But this is a big problem. Very few insurance companies will pay for this, with the exception of places like your Googles, Apples, certain medical institutions. Just recently in Texas, we testified before the legislature saying that this was important and tried to pass a bill that died. But there are about 19 states that do offer this type of coverage for cancer patients or any patients that will be infertile because of medical treatment. But we still have a long way to go in this space.
Absolutely, thank you. And Kelly, do you want to?
The next slide.
I was just curious we have an oncology nurse here. We haven't heard from her about what she sees from her side and what kind of phone calls she gets and so forth. I can't see her name. I apologize. I can't see her name because there's so many names.
That's okay. Yeah, so, we, again, at the clinic visits, we address these with the patient and then connect them as quickly as we can. That is oftentimes a barrier, though, is the time, patients, once they have a diagnosis and they realize they need to get treatment started, right? But those are important factors too, is fertility preserving and things like that, but they don't want to jeopardize getting the ultimate treatment that they need done. So trying to help expedite that is a key piece to this puzzle for our patients.
And then for the surgical morbidity, Andrea, as you asked, there's about a 30% rate of acute morbidity related to surgery for rectal cancer. So that's just short term. And that can range from infections to, poor wound healing, to ostomy complications, things like that. And there's, up to a 3 or 4% rate of mortality in the published studies. We hope it's lower at our institutions, but certainly there is a risk of death. And then long term, it's hard to tease apart what happens from radiation, chemo, surgery, but we do know there's a high rate of LAR syndrome in patients that do have lower anastomoses. That ranges from 30 to 80% in the literature. The definitions are not good. We don't have good tools, and we certainly don't ask the right questions before the patients start these treatments so that we can compare pre and post treatment. But we are working on that in the surgical space. We have task groups together to try to come up with better tools to make these assessments and affect our future patients. The bottom line is there is a lot of morbidity from surgery, both short and long term.
And just to comment on long-term side effects, so there's few areas in oncology where medical oncology has followed pediatric oncology, but survivorship is actually one of those areas. And we know clearly from young children who've had cancer and then go on to live many years post that they often do have many late side effects from treatment, whether it's the development of chronic physical health conditions or psychosocial health conditions as well. And I would argue to you here that a young patient, our patient here is 28 years old, they can have another 50 plus years of life, and a trauma such as a cancer diagnosis at this stage, in which being a young adult is hard enough, you're developing your career, relationships, family building, any one of those issues can be significantly interrupted and halted. We often see in our survivors, many get stuck in life post-treatment, whereas they might be cured of their cancer, but they have trouble completing many of the goals that they initially set out to do. So I would strongly advocate that all of our young patients really deserve lifelong treatment and access to these resources. I'd compliment Manju and others who've really dedicated their lives and their time to supporting patients, but we can't forget about them post-treatment. This is a lifelong diagnosis, and it's really important that we think about what's their life going to be like in 10 years, 20 years, 30 years, and even beyond that, because they're young people and they deserve an opportunity to really thrive in life.
Great. Maybe we can just go back to the slides and or any other comments from any of the panelists. Hadley, any comments from the social work standpoint?
If I may say something, for this young woman following radiation, vaginal something that is preventable with, good guidance and counseling and some, basically information about how to use a vaginal dilator. In our groups, we find that like lots of patients come to know about it after from discussions in the group, that they could have done something that would have, had a didn't impact in their life long term. So from the patient perspective, we would like that everyone who's getting a radiation treatment, if they are sexually, if they are in the age group that they can have sex, they be told about, they can take preventive measures to preserve their sexual.
Absolutely. I think that's such an important point. And as part of our Young Onset Center, we do work closely with our sexual health GYN colleagues and refer patients who'll get radiation early on. And they tell us repeatedly that, as we've said over and over, on this panel, early intervention is key. And this is with vaginal dilators, with pelvic floor, physical therapy, and patients report really significantly improved outcomes with radiation in terms of pelvic floor health and vaginal health as well. So I think that's a really, really critically important point for all of our patients.
Yeah, it's part of our routine. We actually give the patients the vaginal dilators on the last week of treatment with instructions for use. Some of the 85-year-old are a little bit taken aback by that, but we just offer it to everybody. And we also have a very low threshold at our early follow-up. If there are any complaints of dyspareunia or any sexual function issues, we just get them right in with our sexual health group in the survivorship clinic. So I think that really should be the standard of care for management of rectal cancer.
Great. Let's go back to our slide and we can wrap up our case and then open probably the whole forum up for Q&A from everyone. Next slide, please. Next, please. All right, we might be going backwards. Let's go forward, maybe 3 or 4 clicks. Yeah, so she did complete the planned therapy, and fortunately for her, you might have glimpsed at the last endoscopy slide, she did actually achieve a complete clinical response with the regimen that she received. And then we had a discussion. There were some thickened tissue, which we biopsied, and it turned out to be residual normal mucosa. And so she's entered this watch and wait and close surveillance period. She's about probably 2 or 3 scopes into the I think, when she comes to see me, she has the usual level of anxiety. I think we often see in the young patients the return for these, whether it's surveillance after curative intent surgery or whether it's watch and wait. But in the notes, I do see that she's actually self-sought out help from psychiatry and talked about some anxiety in terms of adjustment and so forth. So maybe I can ask Krista to comment on, is this the issue that you encounter in your practice? And, others can chime in as well. Or how do you support these patients?
Yeah, absolutely. Thank you so much. I know my colleague Hadley has some things to say as well, but I think initially when we're meeting with these patients, they're in sort of crisis mode. And a lot of what we're trying to work on is how are they going to live? How are they going to get to treatment? When I think about what we've talked about, all the specialists that we want these patients to see right away, it's over 6 appointments, not including the scans and that just for consultation. So I think when you think about you're someone who was living your life and then suddenly you're immersed into healthcare, medical care, I think the one thing I'm aware of when I'm working with younger patients is that they're completely naive to healthcare. I mean, they quite often have never really, they don't have relationships with their primary care doctors. So then when they have been through it and they're sort of out of that fight or flight mode, in my experience, that's when a lot of the emotional piece can kind of come to fruition. So it's, wow, acknowledgement of what they've been through, the grief of the losses that now they're experiencing, and the angst about life coming, or cancer coming back, or different decisions that they make. A lot of my work is working on coping with anxiety and depression, because a lot of what we talk about as clinical social workers is you didn't go through this whole experience to be left with kind of a terrible quality of life at the end of all this. So using different therapeutic techniques to work with people to sort of help support them into survivorship, maybe even making some goals for the future. I will just say, for people whose cancer does come back, I've just actually talked to someone Friday who was saying it really just feels like a relief, and they actually are having an easier time finding joy because the anxiety of the worry of it coming back is gone, and now they know what they're dealing with. So I think it can be a lot. So we're happy to help through that. And I did appreciate Dr. Roth's comments about survivorship and just continuing to take care of these patients forever. So I mean, obviously we can't see them forever, but getting them in touch with people who are available to help support them. Hadley?
Thanks, Krista. And the only other piece that I would add that is really significant in my work with this patient population is the impact on the family system and the various layers of family. So many of them have young children who they have to communicate with their diagnosis about. Many have parents who are involved, some of whom are aging, who they're taking care of. And so it's such a complex family system that we're looking at. And that is both in terms of social support and family support for the patient, but also how are we supporting the caregivers and the family members in this experience. So I end up working a lot with couples, with families, sometimes just with the caregiver, and that work is equally as important. And then the only other piece that we wanted to make sure to mention is some of the more logistical issues that come up, like financial toxicity. And many of these younger patients are either still in school or just beginning their careers. Some are kind of reaching the peak of their careers or supporting their families. And it has a huge, the diagnosis and treatment has a huge impact financially. And so trying to assess for those issues, but also connect them with resources that help manage the financial burden. So some of that is hospital specific. There are community resources as well that help with that financial burden. So we're doing lots of different assessments at lots of different points, and there's so much that comes up for these patients, which is why the social work role I think is really important.
I wanted to ask everybody, because when Hadley talked about families, I was thinking about our trans patients and our LGBTQ patients, and what are the special issues that arise, both in terms of counseling and in terms of treatment decisions in these patients? I don't know if that can be answered quickly, but it certainly seems like might have special challenges. Thanks.
I just want to address how little we know about these patients. So we know that many adolescents and young adults face disparities in care and outcomes. We actually know a lot less about the disparities within the young adult population. So there has recently been some publications showing disparities in outcomes for racial and ethnic minorities. I think as we start to think more about those individuals who face disparities in the community, we actually need to do this work and this research and understand how can we not just support and care for the population as a whole, but really meet the specific needs. I think that's a wonderful point, and I've not seen any literature or know of any ongoing studies specifically within this area.
Thanks.
I'm sure most of the experience that Hadley and I have had is also just from working with a patient individually and recognizing what their needs, concerns are. I did want to make one more point about families, and thanks, Hadley, for bringing that up. One intervention that our cancer center started was support for kids whose parents have cancer, we have a large group, and it connects the parents because there's just a separate issue of having cancer and how to parent with cancer, but also providing support for those kids. In general, 25% of people going through cancer treatment have kids 18 or younger at home. So it's a silent population. And so supporting that family system and connecting them with other kids who also have a parent with cancer. The other thing I think that has been helpful in the setting where I work, and it's a little different with COVID, of course, is that we do have a drop-in daycare center for that runs Monday through Friday for young families. And I think this has been very helpful for cancer, our patients with cancer as they're going through chemotherapy and radiation, to have a safe place for their kids when they may not have the built-in social support.
I think it's also really important, and I know you mentioned, all of you have mentioned different services, but I think sometimes patients are a little resistant at first because they're so shocked by their diagnosis, right? And what it entails. And so it's just, once again, trying to get the message out that all the various supportive services available should really be taken advantage of. That will really optimize the overall care of the patient.
Yeah, and I want to highlight again that a lot of these supportive services are available in the larger centers, but they're actually not currently very accessible to the community setting. So for many of our AYAs, it's challenging to travel to larger centers, or there's really a need to optimize their care closer to home. And I think there are very few benefits of COVID, as you all know, but telehealth is actually an opportunity to provide care closer to home. And it's challenging as you talk about some of the more specialized services such as radiation oncology, surgery, and other things that really do impact outcomes for these patients. But I do think that many of these patients want to and benefit from receiving at least some of their care closer to home, and we should work on providing access to our specialized resources remotely to the extent possible.
Fully agree.
Especially with rectal cancer.
Sorry, I was just going to say, I think many of the hospitals are utilizing telehealth now, I would hope.
Yeah, what I wanted to say was that especially with rectal cancer patients, many speakers have said that, for a young person, how they're in the middle of so many things in their life. It would make it would be of great importance to have like a roadmap of their treatment, like with rectal cancer. How long is the radiation? How long is the chemo? When will they have surgery? When can they expect to be back at work? And, like some of the side effects may be long term, like you might have to go to the bathroom a lot more frequently for 6 months, and maybe by 1 year you're more normal. So it may be important for the patient to have like the 30-foot or 30,000-foot view of how their life is going to be in the next year. That'll help them plan and kind of, mentally wrap their heads around what is going to happen in their lives. And also to have like a website or a one-chart message with all the links to all the different services they can get, from fertility to sexual health to social service or mental health counseling, all of that, so that the patient can go home and when they feel calm and not like scared and anxious, they can look at these resources and use them better. That would be my request.
Yeah, absolutely, Manju. I think that's an excellent point. I think we can wrap up the discussion and address the participant questions. There were a few questions, a couple on fertility. This was actually a great one. Someone asked, do we know of the effects of immunotherapy on fertility? So as we're moving immunotherapy into early stage curative disease, do we know the effects of immunotherapy? I'll leave that open to the panel if anyone is aware of any data, perhaps from melanoma, where we've had a lot more experience with immunotherapy.
Well, I can start answering that question, and the answer is that we have little to no data on this. Just from experience, my gut feeling is that immunotherapy is not as damaging as traditional chemotherapy, especially the alkylating agents. But I still think we have to be fairly cautious in our counseling. You know, I've called drug companies, I've looked at all the inserts. If they have done any studies on fertility, it's in rats, it's in doses that are not applicable to humans. So it's really not that relevant. But one thing we do have to still think of is even if it appears that, you know, after immunotherapy or even chemotherapy for that matter, eggs can look healthy in terms of the number and quantity, but we really don't know what it does to the quality of eggs or sperm for that matter. So, you know, if this is something that's important to a patient and they can do it, you know, preserving fertility before they see any type of treatment is probably the best course of action. But on the other hand, you know, these immunotherapies do not seem to be as toxic. We don't have great data to say that per se. There are case reports of patients having live births that appear to be healthy at this point when they've been exposed to immunotherapy. But the answer is really that we don't know.
Absolutely, thank you. And then the other question I think we addressed already, Terry, when Kathy asked during the case, just in terms of the financial toxicity, the financial cost of some of this fertility preservation, particularly egg harvesting in women. And I think you've answered that a bit in terms of the progress we're making with insurance coverage.
Yeah, so that's still a barrier. And I think part of the question was about previvors, so people that might be at risk for cancer. I have had a handful of patients who were able to argue with their insurance company that they had a genetic mutation, and that was more of the indication versus an infertility diagnosis. When I say handful, I mean like 2 people that were able to get coverage for IVF with pre-implantation genetic testing. So, you know, if you are a patient that carries a hereditary cancer mutation, I would say take it to your insurance company, argue it, and, you know, maybe you will be one of the fortunate ones to get covered, but for most people, this is not the case.
I would agree with that. And we have also written letters from genetics sort of saying why it makes sense to do IVF and pre-implantation genetic diagnosis, you know, especially in patients with where you also worry about childhood malignancies like Li-Fraumeni syndrome, where we know we can have early onset colon cancers as well, and in like APC, but with familial adenomatous polyposis.
Great, thank you. There's one more question that ties into what you were just talking about, Sophia. Just a young, very young man, 17-year-old, diagnosed with a stage 3A MSI high tumor, but no germline mutations, not Lynch syndrome. How often do we see that? And do we think that might be associated with some predisposing syndrome, or is this just what we call sporadic? We touched on this during the panel, but there's a specific question about
I think that's
this.
that's a really good question. So in a 17-year-old with an MSI high tumor, I would look everywhere for an occult Lynch associated mutation. Actually, I would even be worried about something called constitutional mismatch repair deficiency, where you inherit a Lynch mutation from mom and also from dad. So the child has 2 Lynch mutations. Most often this occurs with MSH6 and PMS2 mutations. And you can have very, very early onset colon cancer. I have a patient who was diagnosed at age 7 with colon cancer in the setting of that syndrome. Usually it's associated with other cancers like brain cancers, leukemias, cafe au lait spots, but sometimes it's not. So I would work that patient up very, very carefully for what I would call occult Lynch. If that patient has any siblings, I think it's really, really important to initiate colonoscopies for that individual. And I just want to go back to that point, even if in our young patients who are genetically negative, I just want to highlight that we really do have to get the siblings colonoscopies. Unfortunately, I have multiple SIP pairs now who are genetically negative, but more than one individual in the family, more than one SIP had an early onset colon cancer. And I do think that in these families, those SIPs are probably at a higher risk. We don't know why, but they're probably at a higher risk. And I think it's really important to do the colonoscopies to prevent this in other family members.
Great, thank you so much. Nancy, I think we have one more question.
Yeah, I think I just want to kind of raise our attention. Sorry, my dog is barking. To one of the comments in the chat, which I think is important, that this relates to bowel function. So either, we always patients who are struggling with permanent ostomy, but I think the other issue is for the patients who have a low rectal cancer who does have GI continuity restored. Sometimes they suffer from Lars syndrome quite a bit. So maybe Dr. Mathis, could you comment on Lars and post-op bowel function?
Yes, so LAR syndrome or Lars happens in, again, unknown number of patients, but probably roughly 50% of patients who have an anastomosis. And we see this in patients who received radiation and also patients that did not receive radiation. So we know while radiation is the biggest risk factor for LAR syndrome, it also happens in patients who haven't gotten that. That encompasses a lot of different things. It can be frequency, urgency, incomplete evacuation, incontinence, or even just leakage of mucus when they're not passing stool. And it can be quite devastating. I try to counsel my patients that for the first year after surgery, so sometimes that's 2 years after the start of treatment, but for the first year that can adapt and the bowel can recover and kind of come up with a new normal. And at least half of my patients will accomplish some, semi-normal bowel function by that time. But we do have a percentage of patients that will continue to struggle with LAR syndrome. There are some other options, medication, there's even suggestion of sacral nerve stimulation. There are other, things we can try before we commit to a permanent stoma. But about 5% of patients who undergo a coloanal anastomosis or a very low colorectal anastomosis will ultimately end up getting a permanent colostomy because of bowel dysfunction that has nothing to do with recurrence of their cancer.
Great, thanks so much. Any other comments about Lars syndrome at all? Otherwise, I'll let Dr. Sursik wrap us up.
Okay, well, I think we're just a few minutes shy, so we'll give you a little bit longer break. I want to thank our panel for a really great discussion, and clearly I think what we've learned is that it really takes a large multidisciplinary effort and close contact and involvement with the patient to optimize care from diagnosis all the way through treatment and into survivorship. And with this team effort and effort and interest, we will make progress in this disease and in early onset colorectal cancer. And thank you all very much for spending the last 2 hours with us, and enjoy the rest of the conference and your Sunday. Thank you so much.